Intraocular pressure, it is the only modifiable risk factor in the assessment of glaucoma. And tonometry, it is the most standard method in the assessment of intraocular pressure. Applanation tonometry was introduced by Sir Hans Goldmann in 1957. Applanation measurements are safe, easy to perform and relatively accurate in most clinical situations. Of the currently available devices, the Goldmann Applanation tonometer, it is the most valid and reliable. The Goldmann Applanation tonometer is based on the Imbert-Fick principle, which states that the force necessary to applanate a perfectly, infinitely thin and dry sphere divided by the area flattened equals the pressure inside the sphere. Because the surface of the cornea is not dry due to the presence of the tear film, the diameter of the tonometer's head that applanates the corneum was set at 3.06 mm. The Goldmann's applanation tonometer consists of measuring prism, filler arm, weight insert, housing, revolving knob with measuring drum. The equipment preparation includes setting the magnification at 10x, switching on the power to maximum light and beam to maximum height with the blue filters on. The angle between the illumination and the observation system is set at 60 degree and measuring drum is set at 1, which is equivalent to 10 millimeters of mercury. When the cornea is indented by this diameter head, the effect of the capillary attraction from the tear meniscus is cancelled. The tonometer's head is made of plastic. The tip has a built-in transparent biprism which divides the image seen through the tonometer's head into two equal semicircles. The requirements include topical anesthetic eye drop, tissue paper or cotton gauze, sterile fluorescent strip, lubricating eye drop. The cornea is anesthetized and fluorescein is applied to the inferior conjunctival fornix to improve the visualization of the two semicircles. The tonometer's head is applied to the surface of the cornea and a variable force is applied to the cornea using a sensitive spring system which is regulated by a dial. The dial is turned in both directions until the inner tips of the two semicircles, which were visualized using a cobalt blue light, meet. At this moment, the examiner knows that exactly 3.06 mm of the central cornea have been applanated. The examiner then reads the value on the dial expressed in millimeters of mercury and estimates the intraocular pressure. Careful attention should be paid by the examiner to avoid complications associated with this test, which includes corneal abrasions and corneal decompensation secondary to topical anesthetic use. The tip of the tonometer should always be wiped with either hydrogen peroxide solution or with a 70% isopropyl alcohol for 5 minutes and be thoroughly wiped with an alcohol sponge. If a soaking solution is used, the prism should be rinsed and dried before use to prevent infection and to avoid a chemical bond to the cornea. Calibration of this instrument should be performed every month regularly using a proper technique, that is at 0, 20 and 60 millimeters checkpoints. The filler arm movement should be noted carefully during the calibration check. IOP measurements with Goldmann Applanation tonometer are limited by the presence of corneal astigmatism greater than 3 diopter. To avoid this, the average of the two measurements are taken 90 degree apart. This can also be done by aligning the tonometer's prism so that the red line of the prism holder is opposite to the known corneal axis of least astigmatism. Sources of error with the use of Goldmann Applanation tonometer. Now the causes for the sources of overestimation of IOP. Those are too much fluorescein, very thick corneas or too steep corneas. Sources of underestimation of IOP, too little fluorescein, corneal edema, thin corneas or excessive contact time. Portable applanation tonometers with built-in biprisms are called Perkins tonometer. This tonometer allows the clinician to measure IOP in supine position. The pneumotonometer can be used in presence of scarred and irregular corneas. Because applanation does not displace much fluid or increase the pressure in the eye, this method is relatively unaffected by ocular rigidity. An excessive amount of fluorescence results in wide mires and an inaccurately high reading, whereas an inadequate amount of fluorescence leads to artificially low reading. Corneal edema predisposes to inaccurately low reading, whereas pressure measurements taken over a corneal scar will be falsely high. Applanation tonometry measurements are also affected by central corneal thickness. Most accurate with the mean central corneal thickness between 537 to 554 microns. Increase in central corneal thickness may give an artificially high IOP measurement, and decreased central corneal thickness an artificially low reading. IOP measured after photorefractive keratectomy and laser in situ keratomeliosis may be reduced because of changes in corneal thickness induced by these refractive procedures. Other tonometers used in clinical practice are pneumotonometer, non-contact tonometer and tonometer. Gonioscopy is an essential diagnostic tool and examination technique used to visualize the structures of the anterior chamber angle. Mastering the various techniques of gonioscopy is crucial in the evaluation of glaucoma patients. Gonioscopy is required to visualize the anterior chamber angle because under normal conditions, light reflected from the angle structures undergoes total internal reflection at the tear-air interface. At the tear-air interface, the critical angle, which is approximately 46 degrees, is reached and light is totally reflected back into the anterior chamber from the corneal stroma. This prevents direct visualization of the angle structures. All gonioscopy lenses eliminate the tear-air interface by placing a plastic or glass surface adjacent to the front surface of the eye. The small space between the lens and the cornea is filled by the patient's tear, saline solution or a clear viscous substance. Depending on the type of lens employed, the angle can be examined with a direct system or a mirrored indirect system. Indirect gonioscopy may be used in patient with an upright position with illumination and magnification provided by the slit lamp. A gonio lens in indirect gonioscopy, it contains a mirror or mirrors which yields an inverted and slightly shortened image of the opposite angle. It is essential that the examination takes place in a room in which the ambient illumination is very low, completely dark if possible, using a thin, short light beam to minimize the pupillary constriction. A drop of local anesthetic such as proparacaine 0.5% is instilled. The forehead must be kept against the forehead band and both eyes should remain open. Then the lens is placed carefully over the cornea and findings noted in all four quadrants. Once the initial examination has been performed and the findings noted, increasing the level of illumination helps in defining the angle structures. The Poschner and Sussman's 4-mirror gonio lenses allow all four quadrants of the chamber angle to be visualized without rotation of the lens during examination. They have a small area of contact and about the same radius of curvature as the cornea. The examiner can detect excess pressure by noting the induced descimate membrane folds. In an open angle, the landmarks from the behind to forward are: first, the anterior surface of the iris; second, the grey colored anteromedial band of the ciliary body; third, the white line of the scleral spur; fourth, the faintly pigmented trabecular meshwork covering the canal of Slem; fifth, the Swalb's line which correspond to a glistening white line corresponding to the peripheral extent of descimate membrane, and beyond this, the posterior surface of cornea seen as a convex dome. If the trabecular meshwork is visible in up and down in whole 360 degree, then it's an open angle. If it is not seen in up and in lower half, it's a narrow angle. Then it is either an occludable angle or a closed angle. Now the patient looks into the angular mirror. If the trabecular meshwork is visible, it's an occludable angle. If it is not visible, then it's a closed angle. Again, it is divided into appositional closure and synechial closure, which is differentiated by indentation gonioscopy. The Saphir system describes the angle between the trabecular meshwork and the iris as follows. The angle between the iris and the surface of trabecular meshwork is 45 degree in grade 4, greater than 20 degree but less than 45 degree in grade 3, 20 degree in grade 2, here the angle closure is possible, 10 degree in grade 1 and angle closure is probable in time, less than 10 degree in slit, here angle closure is very likely, and in grade 0, the iris is against the trabecular meshwork. Here angle closure is already present. It is important to distinguish the peripheral anterior synechia from the iris processes, which are open and lacy and follow the normal curve of the angle. Heavy pigmentation of the trabecular meshwork suggests pigment dispersion or exfoliation syndrome. A line of pigment deposition anterior to the Swalbe's line is often present in exfoliation syndrome called as Sampow-Lechy line. Other conditions that cause increased anterior chamber angle pigmentation includes the malignant melanoma, trauma, surgery and hyphema. Post-traumatic angle recession may be associated with monoocular open angle glaucoma. The gonioscopic criteria for diagnosing angle recession include an abnormally wide ciliary body band, increased prominence of the scleral spur, torn iris processes, and marked variation in the ciliary face width and the angle depth in different quadrants of the same eye. In evaluating for angle recession, it is helpful to compare one part of the angle to other areas of the same eye or to the same area in the fellow eye. Angle structures visible in an open angle. Magnified view of the angle structures. Concave iris configuration. Juvenile glaucoma with prominent iris processes. Very narrow angle recess. No angle structures visible in a closed angle. Peripheral anterior synechia anterior to Swalbe's line in iridocorneal endothelial syndrome, traumatic iridodialysis, large angle foreign body, silicon oil in angle, internal ostium of trab in iridectomy, internal tube glaucoma drainage device. Gonioscopic view of open angle, gonioscopic view of closed angle. Both these techniques of Goldman Applanation Tonometry and indirect gonioscopy are crucial in the evaluation of glaucoma patients and also in patients with suspected glaucoma. So, all ophthalmologists must master this art for a proper evaluation.